Hey everyone, and welcome to this explainer. Today, we're diving into a topic that's absolutely crucial and honestly, deeply fascinating. We're talking about postpartum hemorrhage. Now look, it's a stark reality that significant blood loss after giving birth is actually the leading reason for maternal morbidity and mortality worldwide. And I know, that can sound incredibly intimidating. But here's the truly empowering part. While it is an obstetric emergency, it isn't some unsolvable mystery. It actually becomes a highly solvable puzzle once we understand the mechanics of the human body. By breaking down exactly why this happens, we're going to see exactly how modern medicine can step in and stop it right in its tracks.
Okay, let's dive into this. Here is our roadmap for today. We'll start with number 1, defining postpartum hemorrhage. 2, the first T, tone. 3, trauma and tissue. 4, the final T, thrombin. And finally, number 5, managing the emergency.
Section 1, defining postpartum hemorrhage.
To really grasp the nature of this emergency, we've got to anchor our definition in some hard facts. Postpartum hemorrhage is strictly defined as losing more than 500 milliliters of blood after a vaginal delivery or losing over 1,000 milliliters after a cesarean section. Those are the exact diagnostic thresholds that instantly put a medical team on high alert.
But, here's the reality of the delivery room. Deliveries get messy. It's virtually impossible to measure the precise exact amount of blood being lost in real time. Plus, there's always the risk of internal bleeding that you simply can't see. Because of that, doctors rely heavily on some crucial warning signs. For example, if there's a 10% or greater drop in the patient's hematocrit from their baseline, that's a massive red flag. They're also watching like hawks for changes in the mother's heart rate, sudden drops or spikes in blood pressure, and any drop in oxygen saturation. All of these vital sign changes tell the exact same story. They point to a significant and potentially hidden loss of blood.
Now, what's really interesting about this is how doctors actually divide the danger zone into 2 distinct timelines. Primary postpartum hemorrhage is significant bleeding that happens right away, specifically in the first 24 hours after delivery. Secondary, or late postpartum hemorrhage, is significant bleeding that happens any time after that initial 24-hour window. And knowing exactly when the bleeding starts, that gives the team vital clues about what might be causing it.
And that brings us to the real core of our explainer. The most common causes of postpartum hemorrhage can actually be neatly lumped into 4 main groups. Doctors use a brilliant cognitive anchor to recall these rapidly during an emergency. The 4 T's: tone, trauma, tissue, and thrombin. Nearly every single cause of this type of bleeding fits right into one of these 4 highly solvable categories. So let's break them down one by one.
Section 2, the first T, tone.
To understand tone, we really have to look at the mechanics of the uterus itself. It's a muscular organ wrapped by 3 layers of smooth muscle known as the myometrium. Now, in a normal state, right after delivery, this myometrium continues to contract. It physically squeezes down on the placental arteries right where they attach to the uterine wall. Think of it literally like a giant natural tourniquet clamping those arteries shut to stop the bleeding. But if there's a lack of uterine tone, a condition called uterine atony, the uterus becomes soft, spongy, and, boggy. It completely fails to contract. Because those arteries don't clamp down, you get a slow, steady, and extremely dangerous loss of blood. And as it turns out, this is the #1 cause of postpartum hemorrhage.
So why exactly would a uterus lose its tone? Well, the biological and chemical reasons are actually pretty diverse. First up is overstretching. Things like repeated distension from multiple pregnancies or stretching from carrying twins or triplets can physically wear out the muscle's ability to contract efficiently. Second is simple muscle fatigue. Honestly, it's just like your legs after running a marathon. If a patient goes through a prolonged labor, those uterine muscles can just get entirely too tired to contract. Third, and this is fascinating, is a full bladder. Just because of how the anatomy is situated, a full bladder can actually physically push against the uterus and stop it from cramping down. And finally, certain obstetric medications can play a role. Anesthetics like halothane or drugs like magnesium sulfate, nifedipine, and terbutaline can all chemically interfere with those contractions and increase the risk of uterine atony.
But here is the reassuring part. Medicine has a very clear, step-by-step escalation of care to fix this. It starts with step 1, fundal massage. Doctors will physically massage the fundus, which is the top part of the uterus near the belly button. This physical stimulation actually forces that smooth muscle to contract and harden up. If that doesn't do the trick, step 2 is emptying the bladder, either by having the patient urinate or by placing a catheter to remove that physical roadblock. Step 3 involves giving specific medications that are designed to forcefully clamp the uterus down. And finally, step 4. If it's absolutely necessary, the bleeding can be stopped surgically. It's a highly precise pathway designed to save the patient.
Section 3. Trauma and tissue. Moving on to our second T, which stands for trauma. We're talking about any physical damage to the genital structures, so the uterus, cervix, vagina, or the perineum. And this trauma can come from a few different places. It could be a surgical incision from a C-section. It could be incidental tearing just from the baby making its way through the vaginal canal. Or it could be trauma from delivery instruments like forceps, vacuum extractors, or an episiotomy, which is a small incision made to widen the vaginal opening. The most critical thing to remember here is that any trauma-related bleeding is an absolute emergency. The team has to locate the site and repair it immediately, usually with direct physical pressure or stitches.
But what if the trauma isn't totally obvious? Sometimes bleeding happens in a concealed spot, forming something called a hematoma. Basically, a hematoma is a hidden mass or collection of blood that can go completely unnoticed for hours. So how in the world do doctors spot this hidden danger? They look for severe pain and persistent, bright red vaginal bleeding. And here is the absolute most vital clue: this happens even when the uterus is firmly contracted. Think about it. If the uterus is firm and clamped down, meaning it's definitely not a toneus issue, but the patient still has severe pain and bright red bleeding, the medical team knows immediately to go hunting for a concealed hematoma.
That brings us to our third T, tissue. In a normal delivery, the entire placenta detaches from the uterine wall and comes out intact. But sometimes, tiny fragments of the placenta get left behind. A big cause of this is placenta accreta, which is a condition where the placenta abnormally invades deep into that smooth muscle layer, making it really hard to separate. Another cause can just be pulling a bit too hard on the umbilical cord. So why is retained tissue such a big deal? Because those left-behind fragments literally act like a door wedge. They physically prevent the uterus from clamping down, which leads us right back to uterine atony and heavy bleeding. The overarching goal here is simple. Make sure the placenta comes out totally intact, and if anything is left behind, get it out fast.
Section 4. The final T, thrombin. Thrombin is our final T, and it refers to conditions where the mother's body simply loses its ability to form normal blood clots. To understand this, we have to touch on a rather intense piece of medical jargon: disseminated intravascular coagulation, or DIC. When a clotting disorder triggers DIC, it basically stops a normal clot from forming when there's a bleed. Just think about the sheer danger of that. After childbirth, a woman naturally has small wounds and bleeds. If her body can't clot, a tiny, normally insignificant bleed doesn't stop, and it rapidly snowballs into a massive, life-threatening problem.
So what exactly triggers these clotting failures? Well, it can be underlying genetic issues like von Willebrand disease, where a patient naturally lacks specific clotting factors. Or it can be triggered by severe conditions during the pregnancy itself, like eclampsia or a placental abruption. When thrombin is the culprit behind the bleeding, the treatment has to be highly specific. Doctors have to identify and aggressively treat that underlying cause to get the blood clotting normally again.
Section 5. Managing the emergency.
Above all else, no matter which of the 4 T's triggered the hemorrhage, there's one ultimate, immediate priority for the medical team: maintaining adequate circulating volume. Because blood is pouring out, the immediate danger is that the body's major organs will start failing from a lack of oxygen. So doctors must immediately pump in intravenous fluids and blood products to keep the system full. They have to ensure that the patient's vital organs stay perfectly perfused and functioning, while they simultaneously hunt down the root cause. So the crucial point is how systematically modern medicine addresses this crisis. Think of this table as essentially your ultimate cheat sheet. It beautifully illustrates the direct link between the diagnosis and the treatment. If it's a tone issue, like uterine atony, the fix is massage and medications. If it's trauma, like a laceration, the fix is physical pressure and stitches. If it's tissue from a retained placenta, the solution is intact removal. And if it's thrombin from a clotting disorder, you treat the underlying cause. By organizing all this chaos into these 4 neat buckets, medical professionals can act with incredible life-saving speed and precision.
And that brings us to our final thought, and a crucial question I want to leave you with. When we look at a terrifying phrase like the leading cause of maternal morbidity, it is so easy to feel helpless. But how does understanding the mechanical 4 T's of postpartum hemorrhage transform the fear of an obstetric emergency into informed preparation and empowerment? Knowing that a boggy uterus just needs a massage, or that severe pain despite a firm uterus might mean a hidden hematoma, perfectly equips patients, partners, and families to be active, informed advocates in the delivery room. By understanding the biology, we completely replace fear with knowledge. Thank you so much for joining me for this explainer.
And I really hope mastering the 4 T's leaves you feeling empowered and eager to keep learning.